Greetings. I'm honored to be asked to present in the CUNY GC Stone Center Inequality Workshop video series, and I very much appreciate the wonderful work of the center, led by my longstanding colleague and friend, Janet Gornick. In the next 35 minutes or so, I will offer a presentation that argues critical science for health justice and people's health must be grounded in history and place. But before that, let me start, as I do for all of my talks, by acknowledging that as a U.S. person in Boston, Massachusetts, that I am on Indigenous lands and pay heed to critical Indigenous thinking, and also that I speak at a time when longstanding issues of structural racism and assaults on democratic rule and scientific evidence have come to the fore, all profoundly intertwined with issues of health, place, and health justice. Motivated by the work of our Public Health Disparities Geocoding project and its second training sessions that we conducted this past summer, whose materials will go up on the website this coming fall, that is fall 2022, I will briefly offer some critical reflections on critical thinking for better science and action as framed by ecosocial theory, followed by specific reflections on area-based social metrics, or ABSMs, for health justice, grounding this work in history and place. And since I always start with history, I want to flag that our very first Public Health Disparities Geocoding training, version 1.0, was back in 2004. Our original training was motivated by research I had first done for my master's thesis and then dissertation, which was to use geocoding, at first by hand, and census-derived ABSMs to overcome the absence of socioeconomic data in cancer registry records with the objective of analyzing socioeconomic equities and their contribution to racialized health inequities. I then set up a project to test systematically across multiple public health monitoring systems which ABSMs at which geographic levels could be validly used by cancer registries, health researchers, and others. When we started out, software to geocode was still pretty much in its infancy, and data linkage was uncommon. By contrast, now, given advances in technology, both computers and software, and also in statistical methods, one can simply go to the US Census website, find user-friendly free geocoding resource online, plus a slew of county and sometimes census-tracked area-based metrics linked to myriad health outcomes. But does that mean you should simply use off-the-shelf data? Not so fast. On this slide, I show some of the kinds of output and recommendations our initial project generated, here using the example of lung cancer mortality rates by census-tracked poverty levels, stratified by racialized groups, plus a map of the attributable fraction of premature mortality, here defined as death before age 75, by census-tracked poverty level in Boston. I also list some of our impacts, contributing to a 2010 Health Equity and Social Justice campaign by the Boston Public Health Commission on What's Your Health Code, an 11-state project to use census-tracked poverty data by the Council of State and Territorial Epidemiologists, and the US Seer Cancer Registry System adopting use of census-tracked ABSMs. But our project was never just about data. It was about for analyses for health justice in context. As a window to our critical thinking, one useful place to begin, as it were, is with the very notion of place. It's a word with a fascinating history and etymology, with roots in ancient Greek, Latin, French, Old and Middle English, Spanish, Catalan, and also German, Welsh, Irish, Swedish, and more. The word place initially referred primarily to a town square, akin to a plaza, thus conjoining both people and the places we create to live. However, around the 15th century CE, place took on a new meaning to refer not simply to geographical position, but also social position, as reflected in the phrase, to know one's place, which by definition invokes social hierarchy. Consequently, one can speak not only of the place of the stars in the heavens, or the pride of place of a falcon before it begins its descent from the sky to catch its prey, or the place of passages in a text, or the substitution of one thing for another, that is, in place of, or the number of places after a decimal point, or the place one wins in a competition, but also the spatial and social positions, that is, places which people occupy and create. When a term conjures up so many meanings and associations, thereby serving also, as it were, a placeholder for so many rich ideas, you can be sure its use warrants critical analysis and attention. This way of thinking about place is grounded in the ways of theorizing afforded by the ecosocial theory of disease distribution, which I first proposed in 1994, and whose features I have most recently elaborated in my recently published book on ecosocial theory, embodied truths in the people's health. This slide shows key connected features of ecosocial theory of disease distribution, whose primary objective is to explain population distributions of health, which is a phrase that clearly appears at the center of the figure. Let me quickly review here some key ideas, and the rest of the presentation will bring these ideas to life. First, note that ecosocial theory explicitly is concerned with levels, pathways, and power, and mandates thinking about these phenomena in relation to each and every construct and phenomenon under study. Second, note that levels are conceptualized in relation to both societal and ecosystem levels and locales, since after all, life and health and disease existed on this planet long before humans ever came onto the scene, even as we as a species have considerably changed the terms of life for all. Note also that processes occurring within and also connecting levels, both social and biological, pertain to production, exchange, consumption, and reproduction. Third, note how time is included in relation to both life course and also historical context and generation. Note also how inequitable social relations, in particular involving racism, class, gender, and sexuality, are positioned as both connected and key to shaping population distributions and health. Embodiment, in turn, is one of the four core and conjoined constructs that appear in the upper left-hand corner, which together shape population distributions of health via pathways involving political economy and political ecology. Understanding how embodiment occurs, that is, how we literally incorporate biologically our societal and ecological context, requires grappling with entangled social and biophysical pathways of embodiment, the second core construct. It also requires considering the third core construct, the cumulative interplay of exposure, susceptibility, and resistance at each and every level and in relation to time and history, such as social movements resisting injustice and organizing for equity are every much as part of resistance relevant to shaping population health profiles as our individual level interactions or resilience. The fourth construct, agency and accountability, in turn refers both to who and what at each and every level is responsible for health inequities and also for the research to explain population health. At issue is identifying who benefits from injustice and from research which ignores injustice, and conversely, who is harmed by injustice and by the overt suppression, lack of funding, and self-censorship that can limit research on these issues. The fundamental point is that we, like any living creature, live embodied, constantly integrating and embodying our experiences and exposures for good or for bad. And in the case of our social being, embodiment means we are not a member of a particular racial ethnic group one day, have a particular gender identity or sexual orientation on another, and on still another day have a particular social class or wealth or income or educational level. We are all of these at once, and the same holds for our nationality, immigration status, primary language and literacy, disability, and the places where we live and work. As should be evident then, area-based social metrics, or ABSMs, necessarily engage with issues of power, place, levels, and history. Define an area, and by definition, the question of boundaries comes up. Set by whom and why? Are the areas intended for administrative purposes or political representation? Are boundaries affected by biophysical features, whether made by this planet or altered by people? And are these areas nested in or cut across other relevant boundaries? As for social metrics, how does agency play out? What power relations do they capture? Who is versus isn't visible? Are these metrics based solely on population composition, or do they affect relations between societal groups? Do they capture rules of the game, past or present, that set the terms of societal group relations and injustice? In asking these questions, it is important to be clear about what constitutes an injustice or inequity, as opposed to solely a difference or inequality. In the case of health inequities, at issue are unfair, avoidable, and in principle preventable differences in health metrics between societal groups, and one must also ask, who is benefiting from harm to others? A key purpose of ABSMs for health equity, then, is to help make visible who needs to do what with whom to advance health justice. Two additional corollaries of the ecosocial construct of embodiment are the need to reject biological essentialism and to embrace instead embodied integration. In this increasingly omic, nanoscale-centric, and hyperbiomedical research moment, it is critical to emphasize that the drivers of current and changing societal patterns of disease distribution, including health inequities, are exogenous to people's bodies and reside instead in the body politic. Nor can explanations of disease distribution be reduced solely to explanations of disease mechanisms, since the latter do not account for why rates and population patterns of disease change in complex ways over time and place. It is also essential to distinguish between what I refer to as biological expressions of injustice versus unjust interpretations of biology. The first of these refers to the adverse embodied consequences of exposure to class injustice, racism, sexism, heterosexism, gender binarism, etc., in effect constitute the embodied phenotypes in which injustice is biologically expressed. The second of these refers to how injustice can distort understandings of biology. For example, when observed social group differences in health are presumed to arise a priori from innate biology, allegedly so. Imagine starting instead with a premise of shared humanity and dignity, recognizing that in racialized unjust societies, good luck finding health outcomes that don't manifest as racialized health inequities. This embodied stance, which rejects determinism and embraces historical contingency, challenges the dominant view expressed by the figure to the left, the quincux, designed in 1889 by Sir Francis Galton, who famously coined the term eugenics and who also invented the correlation coefficient in his quest to prove that population distributions, including of intelligence, were a product of so-called heredity, not environment. Seeking to explain population distributions, Galton designed his quincux so that identical pellets poured through a funnel that randomly bounced off carefully placed pins would fall into different bins and produce a normal distribution, with the height of the column reflecting the probability of pathways of descent. To Dalton, the device beautifully demonstrated the properties of what he called the, quote, law of frequency of error, end quote, a law that he claimed, quote, would have been personified by the Greeks and deified if they had known of it. Each element, as it were, sorted into place, finds, as it were, a preordained niche, accurately adapted to fit it, end quote. Now consider the alternative mechanical device shown on the right. It was built by several late 20th century CE physicists who altered the shape of the funnel and pins in order to generate a log normal curve, that is, the logarithm of the values has a normal distribution. Illustrating the interplay of structure and chance, it thus offers an illuminating mechanical metaphor for showing how altered structures can change population distributions, including of identical individuals, and do so by affecting the underlying probabilities of events randomly occurring to these individuals. This means that observed embodied differences between populations are simply that, observed embodied differences in a given context, not clear-cut indicators of innate difference, so-called. Structured chance allows us to see this possibility more clearly, and the structuring plays out over time and different spatial scales as well. The net implication is that an anti-essentialist and by definition anti-racist science is essential, including for use of ABSMs. The point of analyzing scientifically how racism or any other form of injustice harms health is not to prove that injustice is wrong, since it is by definition, nor is the point to do quote unquote politically correct science. Rather, the point is to do correct science, to generate publicly testable and tested knowledge that provides insights into who is bearing the burden of exposure, disease, and death, and to ascertain if these distributions are inequitable. And it is crucial to do this work keeping history in mind. First, the societal history of the problems and data. Second, the individual or life course history in relation to exposure, age at onset of disease, etc. Third, the pathological or cellular history or etiologic period, that is, how long it takes for disease to develop given exposure. And fourth, evolutionary history, to gain insight into the biologies of embodiment. We and all life on this planet live as emergent embodied phenotypes, and understanding how we embody history is key to changing history for health justice. Which brings me to the context of this talk. We live in a world that is simultaneously alive with sensuous life and beauty, and also rampant ecological degradation and destruction. The past 4 decades of neoliberal economics, building on centuries of colonialism and imperialism, have led to a world of growing spatial social polarization, with ever greater concentrations of private wealth, as epitomized by the factoid that in 2019, the richest 1% of the world's population owned 44% of the wealth. Maps scaled to the population metric employed show the US bloated with billionaires, while the African continent, the world's largest, dwindles to the merest thread. The reverse holds for absolute poverty. In the US, where the top 1% own a greater share of their wealth than their 1% counterparts in various European countries, 3 white men now own as much wealth as the bottom 50% of the US population. Corporate taxes have plummeted and the corresponding income and wealth of the wealthiest has soared, and intergenerational economic mobility is on the skids. Longstanding and enormous wealth gaps by racialized groups are also on the rise. And in 2019, the US white median household wealth was fully 8 times that of Black Americans and 4.8 times that of Latinos. The gap for households with children even more stark. And then COVID-19 hit, exacerbating all of these trends, with billionaires ballooning in wealth and number while everyone else lost. As of January 2022, according to Oxfam, billionaire wealth has grown by 43% since the start of the pandemic, with 1 new billionaire created every 30 hours, while every 33 hours, 1 million more persons have been forced into extreme poverty. The idea that place is linked to population health via social and biophysical pathways shaped by power relations is not new. Instead, it can be readily traced to the rise of public health as a discipline in Europe in the late 18th century CE and the increasing use of census data to allocate power and resources. In 1790, the US established the first ever constitutionally mandated census, designed to allocate political representation, hence power, as also tied to the power of the purse, both for purposes of taxation and allocation of federal funds. Also built into the very first census was the differential treatment of enslaved persons and indigenous peoples. Politically, the former counted as only 3/5 of a person, which strengthened the slaveholders' political power, even as enslaved persons could not vote. Among American Indians, the demarcation was between those subject to taxes, that is colonized, and those termed, quote, Indians not taxed, end quote, outside of the remit of US control. Other countries took note of the US efforts, and in 1826, Louis-René Villermé, a leading French physician and founder of the world's first public health journal in 1829, conducted the first ever study to link area-based social characteristics and mortality rates using the then newly available and unprecedented Parisian neighborhood census data. He demonstrated that the geographic patterning of Parisian mortality was driven not by what everyone assumed, that is the so-called natural environment or airs, waters, places, but instead reflected patterns of neighborhood wealth and poverty. This new work made social inequities in health newly visible for monitoring and for action. However, monitoring place-based trends requires stable areas to compare over time. And in the US until the early 20th century CE, census units followed political boundaries, for example, congressional districts and wards, which were subject to gerrymandering. Since then, back then as well as now, many a politician could not resist the urge to choose voters rather than the other way around. In the early 20th century CE, one intrepid New York City clergyman, Walter Laidlaw, who had also studied statistics, was frustrated by the inability to track congregation data by demographics due to changing ward boundaries. So in 1906, he proposed to the US Census that there be a small, consistent, nonpartisan areas used to demarcate and count the population from census to census. In 1910, the US Census began the introduction of such units, which initially were termed sanitary areas because they were immediately used by health departments to determine the health needs of and also public health nurse allocation to these areas. Starting in 1930, as more and more cities adopted use of these areas and their data became increasingly used by agencies and businesses not involved with health, did they become termed, quote unquote, census tracts. Also in this era, a key leader in the American Statistical Association, Walter Whipple, began using census tracts to reveal profound socioeconomic and racialized inequities in health in Cleveland, sparking similar efforts in other cities. The work of our Public Health Disparities Geocoding project, initiated in the mid-1990s, has continued and expanded upon this tradition. The notion that politics, place, and power are bound up with health has a long history indeed. So now let's turn to the sorts of data involved in historical context. First, consider the slide of US geographic hierarchies, and you will quickly see that the fundamental units, or quote unquote spine, are nested and are directly involved in the original purposes of the census regarding geographic divisions for political representation. Yet while some of these areas have political boundaries and others are administrative, all matter for resource allocation, and in the case of American Indian, Alaska Native, and Native Hawaiian areas, sovereignty as well. Moreover, boundaries can and do shift. Census tracts can be merged or split depending on population growth. And as we all know, gerrymandering is in the news, with blocks recombined in all kinds of ways to give incumbent and/or partisan advantage. Consider as well the historical dynamics of racialized categories employed in the US Census. At first, they distinguished chiefly between the free white versus enslaved versus quote unquote other non-voting populations, and eventually included more groups driven by histories of territorial expansion and immigration, both its restriction and expansion. Since 1997, these categories must, as a requirement, conform to the U.S. Federal Office Management and Budget Classification Standard, OMB number 15, Directive 15. However, be aware that what data are crammed into these bins depends in part on the questions asked. For example, while the 2010 and 2020 US Census ended up with the quote unquote same final categories, the 2020 census used more refined questions, leading to different and perhaps more accurate population estimates. Note also that as of this past summer, OMB Directive 15 is under review with new guidelines anticipated in 2024, which will have major implications for all US data that uses any racialized groups, which is basically US data. When it comes to the US Census or any data source, always read the fine print to understand the processes by which the data are conceptualized and operationalized. And always look too for who is missing. Notably, last year, for the first time ever, the US Census asked questions about sexual orientation and gender identity via a new experimental data project, the Household Pulse Survey. This survey was designed to obtain and report out real-time data on the impact of COVID-19 pandemic and provided opportunities to try out new questions, including for LGBTQIA+ populations, for which representative census data at the national level and state level had never existed before. This is a long way from earlier US Census policies, which as recently as 2 decades ago, whereby any same-sex households were treated as a quote-unquote error to be corrected. Again, look at the fine print. What then is the work that ABSMs can do? COVID-19 offers a case example. Early on in the pandemic, during the first crucial months, US national health data on COVID-19 inequities under the prior administration were missing in action. Hard-hit racialized communities, their advocates, and responsive politicians demanded that data be provided, and data journalists stepped up to address the gaps. Heeding the call, our team, including myself and several others, swiftly produced the first data in mid-April 2020 on COVID-19 death rates for all US counties stratified by key ABSMs. In the early days of this pandemic, these place-based data readily revealed that the highest death rates for COVID-19 occurred in counties with the highest poverty rates, highest crowded housing, highest proportion of populations of color. These are systemic problems structured by social injustice, and I emphasize that the variables we are using are not simply quote-unquote proxies or so-called quote-unquote ecologic variables that are a stand-in for individual characteristics. They are contextual measures telling you precisely about the context and communities hit hardest by COVID-19. Building on this study, we turned to inequities in the mortality surge tied to the pandemic, and in early May 2020 reported the first US data on the surge in relation to social metrics, again using place-based data. For the study, we compared the total mortality rate, that is numbers of deaths per 100,000 persons per 2-week period, to the mortality rate for the same 2-week period based on the average for the past 5 years from 2015 to 19. The value of this approach is that it captures all the excess deaths, both those categorized as COVID-19 and those that should have been attributed to COVID-19 were misclassified, for example, due to lack of COVID testing. And it also captures deaths due to the pandemic, but not the infection, for example, due to delays in getting needed non-COVID healthcare, while also accounting for background seasonal fluctuations and causes of death. Using this approach, we computed the excess deaths for every city, town, and zip code in Massachusetts, stratified by their social and economic composition. On this slide, I show our updated analyses from our article published in mid-October 2020 for 2 of our 4 variables. The index of concentration at the extremes, or ICE, for racialized economic segregation, whereby a value of -1 means 100% of the households are in low income and of color, and a value of 1 means 100% of the households are high income, white, non-Hispanic. And then also, secondly, percent of crowded households. The data for 2015 to 19 are adjacent to the 2020 data, and the lines show groups ranging from low to high for each variable. And no matter the metric used, all showed the same terrible facts, albeit most acutely for the ICE for racialized economic segregation. The death rate surged much higher among communities that bear the brunt of racialized and economic injustice. While these patterns may not be surprising, our study was the first to document them and provided critical evidence necessary to inform COVID-19 policies. Moreover, our study, which we conducted in collaboration with the Boston Globe, enabled the reporters to do important investigative reporting on some hard-hit communities our research identified, but which had not yet had public coverage of their hardship. This reporting helped galvanize public health and public awareness in these communities, putting their experiences and needs in context, while pointing to the roles of unsafe workplaces and crowded households as tied to unaffordable housing and not population density as critical to community spread. What about relation to time, a critical topic, especially in the case of a dynamic pandemic? To the extent that any large-scale COVID-19 analyses have used any community data, our own included, they've largely relied on the most recent American Community Survey data, first for 2014 to 18, or since December 2020 for 2015 to 19. But of course, such data missed the economic shocks of the pandemic. Consider first the graph we produced in December 2020, showing time trends in county rates of COVID deaths in relation to different social metrics, including the COVID-19 Community Vulnerability Index, which adds two sets of health variables to the widely used CDC Social Vulnerability Index, which was designed to identify communities vulnerable to natural disasters. What our graphs show is that while county risk did vary by this measure for waves 1 and 2, by wave 3, this metric became increasingly uninformative as COVID tore through the US, including in the so-called heartland. Moreover, as shown by subsequent data now available at the CDC website, the counties stratified by this metric began to diverge again at peak risk in January 2021, rates converge, then they began to diverge, then they converged again, et cetera, et cetera. These data should be a wake-up call about the problems of using static social measures for a dynamic disease as compared to, say, less temporally volatile outcomes, such as cancer incidence or smoking. To start to address this problem, the inset shows some graphs we produced in February 2021, the first to analyze real-time household pulse survey data in relation to COVID mortality data for the 15 largest metropolitan statistical areas. The story is stark. Compounding misery, areas with the highest COVID-19 mortality rates cumulative since October 2020 were also plagued by higher levels of food and housing insecurity. This commingled real-time misery remains invisible on almost all health agency websites. Moreover, as our latest analyses have shown in the case of COVID-19, the full story of disparate population burdens cannot be told using solely sociodemographic or social vulnerability indices. Partisan politics matters too. Shown here are graphs of the US weekly COVID-19 death rate per 100,000 person years in relation to first quintiles of the county level social vulnerability index or SVI, and second, these SVI metrics combined with county level political lean data for the 2020 presidential election. And as of mid-September 2021, with much greater precision in identifying the low versus high-risk counties is achieved by the latter. Again, place matters, both in spatio-temporal and socio-political context. One measure I've mentioned now a few times is the index of concentration at the extremes for racialized economic segregation. What led me to develop this metric was that about 6 years ago, back in 2014, I found myself wondering about what we in public health could do to discern the public health ramifications of growing extreme and racialized concentrations of income and wealth, to bring into view those who benefit from a status quo in which working families are below the poverty line while the proverbial middle is being hollowed out. At issue in part is residential economic segregation, which in the US is heavily racialized. The value of using measures of segregation is because they capture and portray inequity as a social relationship, because segregation by definition involves social groups defined in relation to each other. One cannot focus on, say, solely impoverished persons. Instead, in any such measure, affluent persons are part of the picture as well. However, upon delving deeper into the public health and social science literature, I confronted two problems. First, work seemed to focus primarily on racial segregation, often controlling for socioeconomic position, or sometimes looked at economic segregation, often not taking into account race ethnicity. And the two phenomena were not studied together, in part because technically measures of these two types of segregation typically cannot be put into the same model, given their high, albeit not total, correlation. Second, I found that most studies measure segregation at the city level or above, precisely because spatial social polarization within cities means that the most conventional measures cannot be used for smaller areas. For example, the Gini index of income inequality is the same for a neighborhood where everyone is impoverished and everyone is affluent. And the main measure used for racial segregation, the index of dissimilarity, can only be computed at higher levels of geography because it concerns the extent to which people in smaller units of geography nested within the higher level would need to move to create an even distribution at the higher level. Third, although I did find some newer measures of local segregation, all continue to cleave racial and economic segregation, and they also problematically conceptualize and operationalize it as a relative measure. Rummaging around in the social science literature, however, I came across an intriguing measure developed in 2001 by Douglas Massey, one of the leading US scholars on racial segregation. He tellingly called his measure the Index of Concentration at the Extremes, or ICE, and designed it to be a measure of spatial social polarization, one that could be computed at multiple scales and levels of geography. Ranging from -1 to 1 and calculated by the provocative and deceptively simple formula shown on the slide, the ICE uniquely captures in a single metric the extent to which an area's population is or is not concentrated at one or the other end of the spectrum of privilege and deprivation. At issue are the various pathways involving the impact of the spatial polarization on local education, economies, environments, and ecologies, as well as spatial and economic access to health services. When I first came across the ICE, it had been used in several social science studies and a handful of public health analyses, and the metric was calculated solely in relation to economic data. And results showed that it was associated with various social and health outcomes independent of individual or household level data. My novel contribution was to extend the use of the ICE by creating and testing an ICE not only for racialized groups, but also an ICE for racialized economic segregation, the first of its kind, which is one of the ABSMs that I will now be reporting on more. Here you can see how the greater Boston area easily demonstrates why in the US, the spatial realities of population distributions mean that while within city analyses are important, they often are not sufficient given the regional economies of the joint phenomena of suburbs, white flight, and so-called bedroom communities, inhabited by people who live near to but not in the cities in which they work, thus shrinking the city's tax base. In the case of greater Boston area, one can readily see the extreme concentrations of white persons and high-income persons outside of the city boundaries versus the extreme concentrations of Black and low-income persons evident in Boston. This sort of map provides a big clue that, for example, racialized or economic comparisons constrained solely to within Boston will miss a large chunk of fellow residents of the state living in nearby areas with far more resources. And it also makes one pause to think about the selection effects of which white persons do versus do not live in the city itself, and which populations of color live outside the city bounds. Here is the 2014 study in which we first used the novel metric of the ICE for racialized economic segregation. For this study, conducted within the greater Boston area, we geocoded the records of participants in two prior Boston-based studies I led, the United for Health study of working class Black, white, and Latino workers employed in diverse job settings, for example, light bulb manufacturing, school bus drivers, grocery clerks, etc. And then also the My Body, My Story study, which recruited a random sample of Black and white non-Hispanic adult members from 4 Boston US community health centers. We then linked these records to each individual's cumulative Black carbon exposure at their residential address for the year prior to the date of their health interview, and also to their census tract ICE measures. And as you can see, in models controlling for relevant covariates, all 3 of the ICE measures were inversely associated with exposure, that is, more privilege, less exposure. And the same could not be said for either the participants' household income or their educational level. Additionally, the most extreme effect was observed for the ICE for racialized economic segregation. We observed similar patterns for our study in New York City in relation to infant mortality, premature mortality, here defined as death before age 65, and diabetes mortality. And though this be one city, it's worth recalling that its population size of just over 8 million means that it has a larger population than half the countries in the European Union. Thus, for all 3 outcomes, the greatest relative risk consistently occurred for point estimates for the ICE for racialized economic segregation, with relative risks on the order of 2 to 4, comparing the top to bottom quintile. These point estimates also typically exceeded those observed with the poverty measure, comparing at greater than 30% versus less than 10% below poverty. But of course, census tracts don't exist in isolation, and multi-level thinking about census tracts nested within city towns is warranted. Here we show multi-level results for Massachusetts for our analysis of child mortality defined as death before age 5. The rows show different ICE measures and also the poverty level. The first column shows results for the census tract analyses, the second for the city level analyses, and the third and fourth for the joint census tract and city level, with all models including random effects at the county and city town levels, plus adjusted for relevant covariates. And as you can see, first, regardless of level, the ICE for racialized economic segregation detected the largest health inequities. Second, for all measures, steeper gradients occurred in single-level models at the census tract, which is the first column, compared to the city level, the second column. Third, in the multi-level models, third and fourth columns, the effects remained far stronger for the census tract and were attenuated at the city level. We also have found similar patterns for fatal and non-fatal assaults, police killings, infant mortality, premature mortality, cause-specific mortality for diabetes, cardiovascular disease, cancer overall, and specific cancer sites, as well as deaths due to smoking and also to all non-smoking related deaths, plus cancer incidents. Of note, the finding of greater sensitivity to inequities of the census tract compared to city-town level is not surprising. It's what we would expect, given reduction in variation by aggregating to higher geographic levels. Similarly, our finding that racialized economic segregation packs a stronger punch than solely racial segregation should not be surprising. But I again note that ours is the first such combined measure. The twofold implication is that first, prior research relying on solely city-level measures of segregation has likely underestimated the impact of spatial social polarization on health. And second, census tract ICE measures may be useful to track how growing spatial social polarization, a global phenomenon expressing rising extreme concentrations of privilege and deprivation, are becoming embodied as health inequities. Let me close now by mentioning two additional types of place-based metrics, each of which warrants a lecture on its own. First, for Jim Crow, whose contemporary health impacts remain barely investigated in US research, our first study shows the quick impact of the legal abolition of Jim Crow in reducing infant mortality rates, leading to a convergence in rates among the US Black populations living in the Jim Crow versus the non-Jim Crow states. No such convergence occurred among the white population. What the study also documented was that nearly 2/3 of all Black infants born in the US in 1960 were born in Jim Crow states, and they're now in their 60s. What might this early life exposure mean for their health and for those whose childhood took place when Jim Crow was legal and are now 70 and older? Notably, in subsequent work, we found evidence of Jim Crow effects and breast cancer risk, including breast cancer estrogen receptor status. Second, for historical redlining, which refers to discriminatory policies imposed by the US federal government in the 1930s by the Homeowners Loan Corporation, or HOLC, and which institutionalized racialized economic segregation nationwide. Consider these preliminary descriptive results for Boston, the first of our 3 studies on historical redlining and cancer. Thus, among Boston's 151 current census tracts included in the areas with HOLC designations, 10 or slightly under 7% were in the best categories, green plus blue. Slightly over half were in yellow, defined as definitely declining, and the remaining 41% were in the hazardous designation, colored red, hence redlining. Those in the green and blue categories scored high for the ICE for racialized economic segregation, meaning higher extreme concentrations of non-white Hispanic high-income families, while those in the yellow and red categories scored lower, i.e. had greater extreme concentrations of Black Americans in lower income households. Census tract poverty rates were likewise lowest in the green plus blue, but twice as high in the yellow and red categories. And among women diagnosed with breast cancer, the proportion with regional or distant stage of diagnosis was lowest in the green plus blue census tracts, but fully 10 points higher for those in the yellow and red categories. Hence, whole categories are still discriminating, as it were, among both levels of contemporary neighborhood conditions and the specified outcome. And these findings were upheld by our much more sophisticated multi-level, multivariable Poisson regression analyses, which nested individuals within census tracts and which estimated associations between cancer stage of diagnosis for breast, lung, colorectal, and cervical cancer with both whole grade and census tract characteristics, taking into account age, gender, racialized group. And we also assembled evidence regarding the mediation of historical redlining effects by contemporary census tract characteristics. The larger point is that it is not enough to say that place matters. To guide action for health equity, it is vital to identify the structural drivers, past as well as present, of why this is the case. And so the place in ABSMs for critical science to advance health justice should be clear, with place conceptualized spatially, socially, and dynamically. No matter how much we may roam about in cyberspace or stake a flag in the so-called metaverse for good or for ill, we and all other living beings on this planet live in real places and context, and any science we produce must reckon with these embodied truths. Or to put it another way, as I wrote when reflecting at being at the People's Climate March in 2014, and as part of deepening my critique of decontextualized science and methodological individualism, quote, indeed, the real ecological fallacy is to think epidemiologists or others could ever understand the people's health except in societal and ecological and hence historical context, end quote. I hope this presentation helps bring home why and how the work needed to advance health justice, whether empirical or qualitative or mixed methods research, whether organizing work, policy work, advocacy work, or otherwise, needs always to be aware of the connections and be cognizant that no one piece of work does it all. So as you do your work for health justice in context, grounded in history and place, always ask, who can and should do what with whom to advance health justice, informed by the new knowledge generated. In closing, we live and die embodied. So too does all life on Earth. We are sensuous, conscious, connected, and created both for good and for bad. It is long past time for our sciences to integrate levels and timescales of embodiment from structural policies and structural injustice to submolecular levels across historical generations, with an eye towards revealing what it means to embody dignity, equity, and joy. I hope this brief presentation has afforded you some critical ideas and examples that resonate with and can further spark your own work for health justice. Let us do this work informed by history and a vision premised on social justice, along with deep recognition of our interconnection with and dependence on our wondrous and threatened planet. Thank you.